Welcome to the Ultimate Dental Podcast, the place where you can learn how to create a dental practice and a business life that you love. Listen in with Dr. David Moffet as he interviews successful entrepreneurs and successful business people and successful dentists as they share their business successes, their stories, and their breakthrough ideas, sharing pearls of wisdom that you can take back to your practice and implement immediately so that you can have that great practice with more patients, higher profits, and less stress. This is the podcast where great dental practices meet with successful business processes. Thanks for tuning in to the Ultimate Dental Podcast, the podcast where thought leaders, industry experts, and thriving practice owners reveal their very best tips, tools, and strategies that will help you grow your dental practice faster. Now, here's your host, Dr. David Moffet.
Hi, everybody, and welcome to today's episode of the Ultimate Dental Podcast. I'm your host, Dr. David Moffet. I'm interviewing and broadcasting from New South Wales in Australia. It is Wednesday midday, and my guest today is Dr. Subodh Nanavati, who is in Houston, Texas, and it is Tuesday night, 9 o'clock over there. So Subodh, Dr. Subodh, welcome to the Ultimate Dental Podcast. Thanks for joining us.
Oh, thank you very much, Dr. Moffat. It's my really pleasure and honor to be with you on this Ultimate Dental Podcast. Thank you very much.
No, it's great to have you, Dr. Subodh, and thank you for joining us. Now, Dr. Subodh, you're an oral surgeon, a MaxFax, OMFS, all
Yeah,
those terms.
OMFS, yes.
Yes, and obviously I can tell that you don't have an American accent. Can you
Yeah.
tell me about your journey through dentistry and where you studied and how you became, how you made the choice to go
Sure.
into oral surgery?
Actually, I started my journey in dentistry in the year 1970, about 50 years back. And I joined Government Dental College and Hospital in Mumbai and completed my dental education in the year 1974. At that time, you'll be surprised, David, that I had no idea that there is a subject like oral and maxillofacial surgery within dentistry. And when I heard that lecture for the first time in my third BDS, I thought that this is the subject in which I would like to specialize. And fortunately, in my final BDS examination, I was university first, and that gave me an opportunity to join my residency in oral and maxillofacial surgery in the same institute where I did my BDS. I completed my Master of Dental Surgery in maxillofacial surgery in the year 1978. And from 1978 onwards, I was working as a consultant in oral and maxillofacial surgery, and I used to work as an honorary maxillofacial surgeon in three hospitals. I was a research director in one of the hospital. I was a professor of maxillofacial surgery in one of the dental colleges. And year 2000, I was invited in Saudi Arabia to head Department of Dentistry and work there as a consultant in oral and maxillofacial surgery. And that gave me an international exposure. I worked with Egyptians, British, Indians, Pakistanis, and Bangladeshis, so many different kind of dentists there. And finally, I was selected to chair the they started recognizing that what is known as Sibahi, that means Center for Central Board for the Healthcare Institute, something like JCI. How they have JCI in United States, they wanted to similarly give recognition to different hospitals, and I was given the post of that chairman, and I worked as the chairman of Sibahi for about 5 years. Then in year 2000, I was already 60 years old and thought that it was high time I retire. And meanwhile, my son also became maxillofacial surgeon, and he wanted to start his private practice in Houston. So he requested me that I should come to USA and help him out to establish his practice. So from year 2011 onwards, I'm in USA and working with my son as a director in his clinic. And now we have got 3 to 4 clinics under our care. We have our own dental laboratory, and slowly, we are progressing further to have more and more dental institutes under our care. You know, so this is the way my journey from 1970 to 2024. It's almost now 54 years.
My goodness, that's a very long
Yeah.
career. What has been some of the most rewarding aspects of being of having a career in oral maxillofacial surgery, Dr. Subodh?
The biggest advantage, Dr. David, I had was to work in India for about, say, from 22 years, from 78 to 2000, where incidence of oral cancer is highest in the world. You will be surprised to know the incidence of oral cancer in India is around 60 to 70%. That means out of 100 cancer patients, 70% will have oral cancer, and rest of the cancers will be 30%. Now, this gave me an opportunity to work on oral pre-malignant disorders and oral cancer. And being a research director of one of the hospitals in India, I took up the project because oral submucous fibrosis, you might have heard its name, related to chewing of smokeless tobacco and chewing of erica nut. Now, erica nut occupies a very important place in the Indian culture, and therefore, the incidence of oral submucous fibrosis is also very high. And the two things that leads to oral submucous fibrosis in the stage 1 and 2, the in early stages, patient complains of burning sensation in the mouth, and that first two stages we treat conservatively. Then does we use different kinds of medication, particularly submucosal intraoral injections of steroids. But in stage 3 and 4, the fibrotic bands are so powerful that they virtually close down patient's mouth, and they are not able to eat. They have to complete trismus. Sometimes the incisal distance is not more than 5 millimeters. You can imagine they push the food with their thumb between their two teeth, and you can find indentations of teeth on their thumbs. And how to open their mouths? There was no surgical treatment available in those days. Some doctors were trying in city like Bombay and big cities, but I tried to develop my own technique, and I started using skin grafts to remove the fibrotic bands and cover that raw area created in the buccal mucosa, and cover it with split skin grafts. And that gave me very good results. And I could do this work because I was working in India. If I would have been working in, say, in Australia or Canada or USA, I would not have come across this kind of conditions. You know, so this gave me an initiative or encouragement to go more ahead in the subject of oral submucous fibrosis. Then slowly, I started working on oral cancer cases. Used to work sometimes alone, or sometimes we have a group of doctors working together. Myself, sometimes oncologists, sometimes neurologists, depending upon the extension of cancer and the what kind of surgery we are planning to perform. So this made me more and more interested in oral pre-malignant disorders and oral cancer itself.
My goodness, what a lucky find that you were interested in this because it was so prevalent in India as
Yes,
opposed to
yes,
the rest of the world
yes,
because of the habits that was happening. Um, let's talk about early detection of oral cancer. Now that you're in Texas,
yes.
what do you see as being the early detection processes that are available? Because obviously, with any cancer, the earlier it is detected, the better the result for the patient, and the
Right,
less invasive is the surgery or the radiation or the chemotherapy.
right. Um, Dr. David, oral cancer is one disease. Unfortunately, it has been put under shadows all over the world because I don't know why. People are more interested in studying breast cancer and lung cancer and prostate cancer and cervical cancer and all those things. Oral cancer is being neglected because oral cancer is a subject of dentist, right? But dentists themselves are not interested. So obviously, oral cancer has now become a silent subject. Even if you ask, if you organize a conference and you say that we're going to talk on oral pre-malignant disorders, very few dentists will attend that. But if you say we are going to talk on implantology, about thousands of dentists are ready to attend that conference because implants give them money. Diagnosis of oral precancerous disorders is not financially rewardable because it is not covered in insurance also. So dentists are avoiding that. And so far as diagnosis of early diagnosis of oral cancer is concerned, you will be surprised that if oral cancer is diagnosed in early stage, the 5-year survival rate is more than 80%. But if it's not diagnosed in early stages, the survival rate of 5-year survival rate of oral cancer patients is only 20%. And therefore, early diagnosis of oral cancer is a must and it should be the part of dental curriculum as well as dental practitioners. Now, if you want, we'll just very briefly talk about the various techniques that we can use in our day-to-day dental practice so far as early diagnosis is concerned. Basic is conventional oral examination. When patient comes to you, he may not have come to you for any ulcerative lesion or any growth or anything that may be suspicious oral. He might have come to you for example, gingivitis, or he might have come to you for treatment of dental caries. But as a dentist, it is your responsibility to completely examine his mouth. What is known as conventional oral examination. Both bilateral buccal mucosa, lip, ventral surface of the tongue, dorsal surface of the tongue, floor of the mouth, hard palate, soft palate, everything needs to be examined and record your findings. Then, next technique is using vital stains. Now, there are different kinds of vital stains like methylene blue, toluidine blue, Lugol's iodine solution. Then we have so many different kinds of visual aids that are being marketed like Wellscope and then Visilight and Microlux DLL and so many things. These are visual aids. Then comes various radiological techniques, right? Like we have got just basic is intraoral periapical X-rays, OPGs, then MRIs and CAT scans and all those things come into picture. And finally, the best diagnosis technique is take biopsy. Now here is a big problem. Majority of dental practitioners avoid taking biopsies because they are afraid that being biopsy, they are told that biopsy is an invasive procedure in the sense that you may land in problem when you take biopsies. But I believe biopsy is not invasive. Putting on implant is not invasive, Dr. Moffat. You take incision on the gums, you make a hole in the bone, and you tap the implant into the hole in that bone. It is not invasive. There is no blood coming out, only saliva comes, isn't it? Any
Right.
procedure you perform in the mouth, even if you do scaling and polishing, there is a bleeding. isn't it?
Mm.
Then why do you teach dental practitioners that biopsy is invasive? They have to learn to take biopsy, because biopsy is the final answer to your suspicious oral lesion. Now the problem starts. All these various diagnostic techniques are useful only when you see a lesion in the mouth. Patient comes to you with the history of, he says, I am a smoker or I am a tobacco chewer, I drink alcohol, and then you find a small lesion or ulcer in the mouth, and then you start doing all other diagnostic techniques. But let us presume a situation in which patient comes to you, he says, doctor, I have got habit of chewing tobacco. Suppose he is from India or some South Asian countries, he will say, I also chew erica nut, and I also drink alcohol, and I smoke once in a while. Please examine my mouth for the presence of any oral pre-malignant lesion or oral cancer itself. You examine patient's mouth, carry out clinical examination, you don't find any lesion. And then you tell that patient that, oh, you're lucky, you don't have any cancerous lesion. And in future, you are not likely to get any cancer. Is your answer is right or wrong, Dr. Moffet? What do you think?
It's wrong because unless you're Nostradamus, you can't predict the future.
Exactly. Because once the cancerous lesion appears in the mouth, it may be a small ulcer, 2 millimeter in diameter. Still, it is too late. It is too late. You have to tell your patient or diagnose the oral precancerous lesion before it appears in the mouth. That means before any morphological changes take place in the oral mucosa. Then how you are going to do it? You have to use biomarkers. And that's why I always say that chemistry comes first, then comes physics. In the sense, the biomarkers will appear in the mouth or oral mucosa first before any morphological changes take place in oral mucosa. So, ideally, if any patient comes to you with a history of either tobacco chewing or alcohol or smoking or any other habits which can lead to oral cancer, and there is no lesion present in the mouth, still you have to carry out biomarker studies. Unless you don't carry out biomarker studies, you will not able to predict whether this patient is likely to develop cancer or he is likely to develop oral pre-malignant disorder, which eventually lead to cancer. And this fact needs to be put into the minds of all the dentists. Unfortunately, as I told you before, it doesn't give you money. Insurance companies don't give cover this test and anything, and therefore 90% of the dentists are avoiding dealing with oral precancerous lesions. You know.
Dr. Subodh, these tests for biomarker studies, and
Uh-huh.
I've had one. I completed a questionnaire randomly that was put to me, and because of my history of being a smoker 40 years ago, since I gave up smoking, and I only smoked for 6 years, and the fact that I still consume alcohol a couple of days a week, that put me in that high risk category. And
Yes.
so I had the test, which I had to have because it's not available in Australia. I had to buy it and get it shipped to me from the US, have my saliva tested, have it sent back to the US for the results, and then had the results read to me. I was quite apprehensive, knowing that if the results came through positive, then there was to be more investigation. And you're right. I've told you about the case of my brother-in-law, my sister's husband, who was my patient for as long as he was married to my sister. So Um, it's 23 years he was my patient, as I've been retired 7 years. But after I retired, he was diagnosed with throat cancer, and so I had not ever noticed any lesions in his mouth at all. It was early days. He was treated with radiation and chemotherapy, surgery too difficult, and very good prognosis. Done, diagnosed early. But in the back of my mind, I wonder, was it something that may have been visible that I did, that my team didn't see? I don't know. And he, in the time that I knew him, not a smoker. He may have smoked beforehand, but he was in Vietnam. And of course, chemical warfare was used in Vietnam. So anything was possible. But scary. It's scary. Any diagnosis of cancer is for the patient is very scary. So anything that can help the public rest easy that the biomarkers in saliva is a very um, dramatic test for them to
Yes,
have in terms
yes,
of getting
yes.
some clarity moving forwards.
Dr. Moffat, I would like to also add one more important point, that if any patient comes to you, for example, let us say you were a smoker, right? And you were told to stop smoking. So whenever you tell any patient to stop smoking or stop chewing smokeless tobacco or stop smoking, I mean stop drinking alcohol, from that day onwards, you are not free of danger of developing oral cancer, because after you stop your habits, you are likely to develop oral cancer for next 20 years.
20
Can you
years.
imagine?
20 years. My goodness. That's
Now suppose today is year 2024. A patient comes to me today and I tell him that please stop all these habits, otherwise you are going to land into cancer. And patient agrees and he stops all the pathological oral habits. But I still have to examine him at least once a year from 20 years from today onwards. That means from 2024 to 2044. Because in next 20 years, in spite of the fact that he has stopped smoking, he has stopped chewing tobacco, he has stopped drinking alcohol, still he is likely to develop oral cancer. And this is the fact. Sometimes you might have heard that I have stopped smoking, still I got oral cancer. Because the, those pathological chemicals are still moving into your body,
yes.
and they may harm your oral mucosa or any other organ where the cancer can develop. And therefore, dental practitioners not only need to educate patient, but they have to follow them for next 20 years. That means it's almost whole life. I would put it this way, you know. Otherwise, you can't control oral cancer. It is not one visit or two visits or three visits problem. It is lifelong issue, and every patient, irrespective of the fact whether they come to you for dental treatment or an implant or whatever reason, you have to examine them and see that they stop their pathological habits and continue examining them for next 20 years.
20.
Otherwise, you will miss cancer diagnosis 100%.
So the future of oral cancer screening is consistency. I guess it's like a lifetime for women of
Yes.
mammograms for
Yeah.
people with fair skin, annual visits to the dermatologist.
Yes.
I've met people who have to shave their head every year because
Correct.
they want to make sure there's no cancers on their scalp.
Yeah.
What advice can you give to general dentists on integrating effective oral cancer screening into their routine examinations, Dr. Subodh?
I think that first of all, they must take proper history of the patient, because if they don't take proper history of the patient, and record this whole history, like means that means their age, their sex, their food habits, and their smoking habits, alcohol habits, any habits related which could lead to HPV, human papilloma virus infections, anywhere in the mouth or in other areas of the body. And then, depending upon the history, they have to decide to carry out their routine oral examination at least once a year, if not every 6 months. And suppose patient comes to them, to the dental practitioner, with any positive history of oral pathological habits, they have to carry out what is known as you said, salivary biomarker studies, so that they can predict whether this patient is likely to develop any precancerous lesion or oral cancer in the next future, within a few days or few years. And the most commonly used salivary biomarkers to predict development of oral cancer are two. One is loricrin, another is filamin A. This salivary biomarker, you collect saliva and send it to laboratory, and if they come positive, that means this patient is heading for oral precancerous lesions. And you have to be alert, call them regularly, ask their history, examine their mouth correctly, and again carry out biomarker studies. And if the biomarkers are increasing in numbers or their concentration is increasing in oral mucosa, you have to be more and more alert and examine them routinely before they develop any oral cancerous lesion. You know, and this is the way I think we can prevent cancer. Otherwise, there is no way. I mean, sometimes I come across patients who are neglected just like that, and patient had some kind of lesion on their tongue, but dentist never bothers. And in spite of that, he will put implants and puts fix these bridge and this and that, and then forget about ulcer. And as you said, Eva had a similar experience. And recently there was one case, I don't know where it took place, where the dentist forgot about ulcer on the tongue, and then she developed cancer there. She filed a suit against that dentist, and the dentist had to pay $18 million to that patient.
Yeah,
$18 million. Can you imagine?
it's I
So, therefore, I feel that oral cancer, particularly pre-malignant disorders, need to be thoroughly studied not only by maxillofacial surgeons or an oncologist, but general dental practitioners as well. Unfortunately, even dental institutes are not taking proper, understanding of this subject, and they are not teaching dental students about oral pre-malignant disorders. You contact any dental manufacturer, you'll be surprised. Viome has collaborated with Henry Schein. You know that,
yes,
isn't it? And if you ask any Henry Schein representative, if he comes to you, that what do I mean, what is that something like salivary diagnostic? What is that? He will not tell you anything because he is not told to tell you anything. They are more interested in selling those products which gives them money. See, that's the problem. The problem is all stakeholders in this diagnosis test are more interested in making money rather than saving lives, you know. So this whole attitude, this whole thing needs to be changed if we want to control oral cancer. Otherwise, within next 20 years, today one patient dies every hour in the world because of oral cancer. After next 10 years or 20 years, you will find 10 patients dying every hour because of oral cancer, you know. So we need to introduce proper screening methods, like have mammograms. All women above age of 40, they undergo mammograms every year, or pap smear for cervical cancer. right? Like this, we have to introduce biomarker studies, point of care, microfluidic diagnostic techniques. In the sense, suppose you are working in some remote area and you have no idea or you don't know anything about oral cancer, but at least you can collect saliva. There is a salivary test collection, I mean, salivary collection apparatus are available, and send it to laboratory and try to find out whether this guy is likely to develop oral cancer or not. At least this you can do, isn't it? You may not have maxillofacial surgeon in your village where you are practicing, or rural areas, or those patients who are not economically possible for them to travel to bigger cities or bigger oncology centers to get them diagnosed. At least point of care diagnostic test needs to be carried out. Then and then only we will be able to control oral cancer, not otherwise. You know.
So the test for the biomarkers has to be a salivary test where it's a sliding scale. It's not just a positive or negative, but it has to be your low
Yes,
risk, medium risk, high risk,
yeah,
and
high risk, medium
and
risk.
and since your last test, this is where your vector is changing. You've
Yeah,
now moved from this number to this number, and so
yes, yes,
it's
yes.
got to be it. Yeah, it's not like it's not like a COVID test where you're either positive or negative.
No,
Off you go. It's got to be that sliding scale. So you're right. It is the dentist's responsibility,
yes,
and I know you mentioned Viome, and they are at the forefront in terms of oral cancer screening. But one of the things that dentists should be aware of, as you mentioned too, is that should a patient be misdiagnosed or undiagnosed and an oral cancer presents on one of their regular patients that presents visibly, and the dentist has missed this or missed following it up, the results for that dentist and that dentist practice and that dentist family and that dentist's life can be devastating emotionally for that dentist. The fact that they have affected somebody's life because of their misdiagnosis or undiagnosis.
correct,
And
correct,
that needs
correct.
to be emphasized to the dental profession that although it may not be something that is going to make them money, is going to be something that is going to give them better quality of life if they are 100% on board and thorough with all testing, considering that now oral cancer is not just caused by smoking, it's also caused by HPV virus, which is um, you know, as my um, uh, dentist who gave me my results said. He said, now we can't smoke, we can't drink, and we can't have sex anymore. You know, these are the three high risk things.
Yes,
And
yes, that is.
so people can still engage in those high risk things. Obviously, smoking is socially
Yes,
voodoo these days, but they can at their own risk, knowing that they can at least be on top of this with these testing um, kits that they can get from Viome, and they're very and that's who I did my test with. Very simple to use at home. Um, First thing in the morning, e- much easier than bowel cancer screening to use, and off and because we're talking here in terms of the area that needs to be treated, Dr. Subodh, we have to be on top of the diagnosis because there is just so much going on here in terms of nerves, arteries, veins, brains, everything, as opposed to
right.
down in the abdomen, there is less congestion of those important pathways, neural pathways and vascular pathways. So it is really important to get onto it.
True.
I understand now that the Viome test is becoming even more affordable. Looks like it's going to be even more affordable for patients, which means that it's also going to be more affordable for governments to subsidise or provide it as well as it should be in terms of keeping people out of hospital, keeping people alive. You know, that's governments have to. You know, their role is to keep taxpayers alive. You know, because they pay tax. they don't want them. They don't want less taxpayers. They want more taxpayers. So they need to be invested in this as a mandatory screening process.
Right.
But you are right on top of this in terms of how do we get the general dentist to come on board? And I think the general dentist needs to, you know, nobody likes to think that they have to go in battle with an insurance company or a patient and lawyers. You know, that's the ultimate in terms of a bad case scenario. The advancements in the biomarkers recently and the imaging techniques as well, how has that improved in the accuracy of the oral cancer screening?
Of course, we'll go through that also. But before we go ahead, I would like to also add one important point so far as salivary diagnostics are concerned. It not only gives us biomarkers, results of biomarkers, but it also gives us our presence of various microbiome or microbes in our mouth. That is known as oral microbiome. Now, why oral microbiome is essential? Because if you go through some of the publications, you will realize that those patients who are likely to develop particular type of cancer in the mouth or oral pre-malignant disorder, they have particular kind of bacteria in more numbers than a normal person. Like, for example, suppose you are having more Candida albicans in your mouth, then you are likely to develop leukoplegia rather than those who have normal levels of Candida albicans in their mouth. Why? Because Candida, some species of Candida albicans, that fungi, that white coating tech that plays in your mouth, they produce nitrosamine. That's a chemical which is
Yes,
present in tobacco. So, if you chew tobacco, then also you will get oral cancer. And if you have more Candida albicans in your mouth, then also you can get oral cancer. And therefore, not only biomarkers, even presence of certain kind of bacteria or fungi or virus in your mouth, like HPV, we all know, they can lead to oral cancer. And one point which I have been very sensitive about is early days, about 300, 400 days, dentists were only removing teeth and making dentures, right? And they
yes,
were not called doctors. They were technique sort of like a mechanic repairing bicycles and all those, like plumber or fitter, something like that. They were not considered as lifesavers. But when slowly dentistry progressed, today we have got endodontists, prosthodontists, maxillofacial surgeons, orthodontists, and we are all called doctors. Our degrees are Doctor of Dental Surgery, isn't it?
yes,
Then, if you want to call yourself doctor, you go to any medical professional. He may be internal medicine specialist, or he may be radiologist, he may be pathologist. Why they are called doctors? Because they save your life. Now, if you want to call yourself doctor, you have to learn to save life. Otherwise, remove doctor from your name. You are not Dr. Subodh Nanavati. You are just simple Subodh Nanavati who removes tooth and make dentures. That's all. And Dr. Moffet, I have been working since that about 40 years as a maxillofacial surgeon. And I have realized one thing in my this whole experience. If you save one life, 10 other patients will come to you which who will pay you more money than normal. I used to treat, say, for example, in a family comes to me, in their family, I might have treated a fractured mandible or I might have removed a leukoplakic patch from their mouth and given skin graft there. So that whole family, we feel that, oh, Dr. Nanavati is a great doctor. So they'll bring one of their patient to me for making denture. So I will tell them that, see, you see, I'm a surgeon. I'm not prosthodontist. How can I make denture for you? You said, no, no, you saved my son's life. You saved my own life or my wife's life. So making dentures should be very easy for you. If you can perform, if you expose whole mandible and put plates there, and you are able to save lives of so many patients, then making denture is not that difficult. So what I will tell them, normally suppose you charge say $3,000 for a denture. I will tell them I'll charge you $10,000. They will pay me $10,000 because they are sure that this guy is not going to fool us. They've saved life of one of our patients, one of our family members. So dentists should realize this also, that if you do one good thing, the nature will provide you with so many other good things. Try to learn save lives if you want to call yourself doctors. Otherwise, dentists should not be called doctors. They let us go back 300 years back, 400 years back, you know, and remove tooth, put implant, and put denture. That's all. Don't do anything else. Let patient die. Is
Yeah,
that good?
no, of course not. Of course not. You know,
Ah,
it,
see,
it,
I don't understand these things. Why we are not understanding our responsibility? Government is paying to establish so many dental colleges, so many professors are working. We are, people like you are trying to educate people, educate dentists, and still we are not ready to learn anything. You know, we just want to make money, have a big house, have 2 3 Ferrari cars with us, go to vacation and enjoy life, marry more than one or two times, you know, and then what is this going on? I really sometimes I feel that possibly I have selected a wrong profession. I should have become a medical doctor rather than a dental doctor, you know, because we have to learn to save lives. If we don't learn how to save lives, eventually dentists will go back what they were 300 years back. They'll all be regarded as just plumber and fitters, nothing more than that, you know. So this point also needs to be, it touches your heart, it touches your emotions, sentiments, that you are missing something which you are supposed to know, isn't it?
it
So
is.
this needs to be emphasized, you know.
I think you've covered a really important point there in terms of making sure that proper history is taken each and every time regular patients are coming for their regular visits. Um, in fact, I I'm I go to two dentists. I go to one on month 3 and month 9, and one on month 6 and month 12, and have my teeth cleaned 4 times a year. And I think one dentist knows I go to the other, but the other doesn't know that I go to both. But at my last visit, the dentist came out and he said, "Have you got any aches or pains?" I said, "Well, I have, but they're not in my mouth. You know, they're in my hands and in my back, in my legs, but not in my mouth." And so that was the extent of my medical history. And of course, it does need to be more detailed, and we do need to be making sure that these, because as dentists, we do have the opportunity of looking in people's mouths. As doctors, not so much. I don't think I've ever had a doctor look for an oral cancer in my mouth.
No,
Um, and one doctor once told me, socially, he said, really, he said, most general doctors out there, it's they're they're basically just treating coughs, colds, and sore holes, and that's what he said. And coughs and colds, it's, oh, you look sick, you're coughing, get this medicine into you. So sore holes is I've got a sore mouth, better go see a dentist. Well, you're right. Dentists are only really interested in hard tissue structures inside the mouth, very
right.
little on soft tissue, and even the education of um, the general public, let alone the education. I once had a physiotherapy ask me, "Are cleans at the dentist necessary, or is it just the way for the dentist to get an extra $100 or $200 from me at the end?" I said, of course they're necessary. You've got disease, you've got infection. You need to be getting that out of your mouth on a regular basis. So
True.
moving forward from that, you're absolutely right. We have to make the public more aware. We have to make the government more aware of the importance of oral cancer screening. And the interesting thing, as you said about the Viome test, is the other non-cancer biomarkers which give an indication of other conditions. Your risk of decay, your the risk of dry mouth, which then affects so many things as well. So it must become a necessary test. and
Yes.
and I think, as I alluded to, or as I mentioned, that pre-appointment questionnaire putting me into a high risk category, which then prompted me, well, I need to take the test so that I need to know where I am. I can't be walking around with this possible in my back of my head. I need to know
Right.
exactly where I stand. And so, we need to, the dental profession has an amazing reputation within the medical profession, in that
Yes.
we
Yes.
have the ability to get people to come back on a regular basis every 6 months. Doctors can't do it, pharmacists can't do it. We are the envy of those professions. So we should capitalize on that for the benefit of our patients, to say
Correct.
this is going to save your life.
True. Very true. And if even patients who visit dentist, you know, and the dentist, for example, fails to examine his whole mouth, the patient should insist, the doctor, please examine my whole mouth. If you don't examine my whole mouth, you are going to land in trouble. It's a negative way of doing things, but that's the only way I think dentists will learn to completely carry out whole mouth examination. That needs to be done.
It's a tough situation, Dr. Subodh, because out there, as you know, having lived in America for uh, a number of years now, the general population, the obesity rate is just rising,
Yeah,
and the population has no concern. That's stuff they can see that is wrong, but they just keep doing they do the things that cause that obesity to stay there. They don't do the things that will reduce that obesity. It is very hard to find somebody who gets you're pre-diabetic. Oh, I better start exercising. A lot of people
yeah,
go, oh, pre-diabetes. What's the medication?
yes.
That's
They
not the
want
answer.
easier way to treat it
Oh,
rather
yeah.
than, yeah, that is true.
Can I take a pill for it? Yeah. Is there a pill for it? But for every pill, there's got to be a side effect as well. And so, medication is not really the answer. I
Yeah,
think
yeah.
that I'm excited about what we've discovered through meeting you, and about Viome, and this pre-cancer biomarker test. It's exciting times for the dental profession to really have an impact on the lives of their patients, their
Right,
their, their
right.
family situations. Cancer is a devastating illness when it strikes any member of the family. It gets everybody concerned and worried, no matter what sort of cancer. But oral cancer is scary because can't be seen, and can't be often know whether we got it all. We just talk in terms of survival rates. And
Right,
so
right,
this testing from Viome is really important, that we 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 get this into as many dental practices as possible, to keep their patients alive, but also to prevent lawsuits for dentists.
right.
Um,
Because, yeah, please go
yeah,
ahead.
go on.
No, you said about lawsuits. So, if once the patient realize that diagnosis and screening for oral cancer is a dentist's responsibility, and then I believe that if we don't carry out proper examination and screening tests for oral cancer, more and more patients will sue the dentist. And once they have to pay millions of dollars to their patients, in which case they have missed the diagnosis of oral cancer or oral pre-malignant disorders, then they will not only sort of harm their prestige in the society, but their whole financial situation will go to zero level. So we dentists, to prevent ourselves from suffering financial loss or prestige, professional prestige, we have to carry out proper screening for the presence of oral pre-malignant disorders and oral cancers. I think that should be the final, we have to do it. Otherwise, we are going to, harm ourselves in future. Because more when people realize that my dentist missed this, my dentist missed that, my dentist missed that white patch or red patch or whatever swelling or whatever is there, then they will start suing dentist.
Yeah, nobody wants to be chased by a lawyer.
Yeah,
They they're they don't give up. That's for sure. It's not a pleasant experience for any person to have to be in a court. It's very uncomfortable for everybody. I've been in courts. I've watched how they behave. It's a completely different environment in there, and it's not like the movies, and it's not like the TV. It's vicious.
yes,
I think that we've got to get the word out, Dr. Subodh, about oral cancer screening and this salivary test for biomarkers is the answer. Dr. Subodh,
yes.
thank you very much for being a guest on my podcast. How can viewers of this podcast, listeners to this podcast, how can they get in touch with you if they need to?
You can just email me, whatever is there.
All right, so send you an email, and of
Okay,
course, you are also an educator. They can find you on the advancemyce.com
yeah,
platform as well.
right,
So
right.
we can get in touch with you there. And Dr. Subodh, I don't think that any dentist watching this will not be motivated to take that step to, I need to do more for my patients. I need to do more for my practice. I need to do more
Sure.
for my family in terms of helping my patients to avoid um,
Yeah,
the, the, the disruption of a diagnosis of oral cancer. It's not pleasant.
yeah.
Dr. Subodh Nanavati, thank you very much again for being a guest on the podcast. I really appreciate your time. I know it's late where you are, and as always, it's been a pleasure talking with you. Thanks, Dr.
Thank
Subodh.
you very much, Dr. David. Nice meeting you again. Thank you.
Thank you for tuning in to another inspiring episode of the Ultimate Dental Podcast. We appreciate each and every one of you for being a part of our dental community and joining us each week on this incredible journey. If you found value in today's episode and you don't want to miss out on future episodes packed with expert insights and actionable strategies, here's how you can stay connected with us. Firstly, hit that subscribe button. Whether you're listening on your favorite podcast platform or watching on our website, subscribing ensures you'll never miss an episode. Secondly, share the love. If you know a fellow dentist or colleague who could benefit from the wisdom and knowledge that we share here, please share our podcast with them. Also, please share the podcast on your socials by simply clicking on the social icons wherever you view or listen to this podcast. Together, we can all do our bit to elevate the dental profession. And finally, stay engaged with us. We love hearing from you. Your questions, comments, and feedback fuel our mission to provide the best content for your professional growth, your personal growth, and for your practice growth. Remember, your journey to creating a dental practice and a business life that you love is our mission, and we're excited to be your trusted guide along the way. Thank you for being a part of the Ultimate Dental Podcast. Until next time, keep smiling, Keep striving and keep on tuning in to the Ultimate Dental Podcast.